myself, Dr. Narayan Prasad Sahu, Head of the Department Anesthesiology at Spice General Hospital. With me, Dr. Krishnamurthy and Dr. Ravi. We are here to discuss on chronic pain management. Dr. Krishnamurthy, Dr. Ravi, I am very much grateful to both of you. You came all the way from abroad and from Chennai to as an expert to our 47th annual conference of Indian Society of Anesthesiologists. I'm really grateful to you people, sir.
Thanks for inviting me both, and I'm very privileged to be here. I am Dr. Krishnamurthy. I'm a practicing pain consultant in Wrightington, Wigan and Lee Infirmary, which is in England. And I practice both anesthesia and chronic pain, 50% each. And I'll come back to you again.
Dr. Ravi, sir.
I'm Dr. Ravi Krishna Kalathur. I'm a consultant pain management services at Apollo Hospitals, Chennai. I thank you very much for the opportunity given to come to Rourkela.
Thank you very much,
sir.
Sir.
Thank you.
Sir, your topic is chronic pain management. Okay, sir. What do you mean by pain, sir? Krishnamurthy, sir. Yeah. What do you pain?
Pain. We all know pain. Pain. We all experience pain at some point. And pain is actually a protective, sign and symptom. If you don't have pain, we won't be able to live. But the difference between chronic pain and acute pain is acute pain settles in few weeks' time or few months once the cause is sorted. But chronic pain is pain which lasts even after 3 months or 6 months, even after the cause which caused the pain is settled. Okay, so the International Association for the Study of Pain defines chronic pain, it's not acute pain, chronic pain as an unpleasant sensory and emotional experience because of tissue damage or because of potential tissue damage, and it will last even when the tissue damage has been healed. Okay. So that's the big thing about chronic pain. People don't know why they are in this pain, and then the society fails to accept and recognize their pain, which is not visible.
Okay, what is the implication, sir? What are the implications of chronic pain?
So, to me, the implication is, it's been the definition for pain, what Dr. Krishnamurthy was actually enumerating was way back in 1972. We're still talking about pain or basics of pain or whatever the pain is causing, whatever potential implications that it has. So first, we need to recognize pain. It is very, very common scenario in our society, in our daily practice, in our fraternities, medical fraternities. Oh, we don't know what this pain is coming from, send to a psychiatrist. So first thing is to sensitize our own fraternity. That is the first thing that we can do. Another thing, pain itself, the implications towards the patient. Yeah. First, the family should be able to understand. They don't see a cause to it. Yeah. They don't see a cause, but they see a patient suffering. They don't know. For a few months to few years, they will accept it. And then they would start believing themselves that no matter what you tell him, he's still going to come, he or she is going to complain and pay. So it takes a toll on the patient and the patient's family as such. So by and large, it actually decreases whatever functionality is left in that person.
It has got both physical and emotional component.
Absolutely. So it brings down the entire family. And of course, it brings down the society as such, the value that is added to the society also.
Krishnamurthy, sir, so what are the managements? Do you have, about chronic pain? How do you manage this type of patients?
Yeah, as he said, chronic pain is itself, people think that chronic pain is a symptom of a disease. Yeah. But what we feel is chronic pain itself is a disease, just like diabetes, blood pressure, it itself is a disease, okay? And when it happens, when there is pain for when somebody suffers from pain for more than 6 months or 3 months, it has wide implications. One of the commonest things is their mood is affected. their sleep is affected. They can get depressed. They can get anxious because of all these things. Their relationship with their family, with their colleagues, everything is affected. And that will stop them from going to work. They won't be able to go to work. They lose their work. When they lose their work, they lose their income. And finally, that causes more depression. And when they are in depression, depression and pain goes hand in hand. When somebody is low in mood, they feel more pain. And when they are in pain, they lose their sleep and they get more depressed. So it is not a single problem. Like, if you have acute pain, take some paracetamol, take some ibuprofen, take some rest for 12 hours, you are sorted. But chronic pain is a multi, it has got biopsychosocial implication.
Yeah.
So if you ask me, how will you manage, maybe it might take another, 4 days for me to explain.
Yeah,
but in nutshell, you need to treat the patient as a whole. So you need to treat the pain, physical component of pain, and then you need to treat the emotional component, and then you need to also look into the social and financial. Even though as a doctor, it is beyond our control, but we need to look into those, specific things. But there are, during my visit to this country, over the few years, I've been saying that the pain management is improving each year. It's getting better, and whatever techniques we have in United Kingdom is also available here, even though it's not available for everybody, but it has started to come. Okay, so if you want specifically, what are all the, how you can be managed? Do you want to take
Dr.
over?
Ravi, please tell me, in your common practice, you are practicing since so many years. What type of pain patients you are getting and what treatment you are giving to them?
Okay. See, I've only been practicing pain for the past 12 years.
Okay.
My everyday practice, would see a lot of low back aches.
Pains,
Sorry.
It's very common. Low back
The low back ache is a very common. We have a host of causes for causing low back ache, but then there are the non-specific ones which are also turning up, be it post-surgical pains, cancer pains. We see a lot of neck pains now because of the over utility of mobile phones, lifestyles, and so on. So we see a lot more neck pains. Of course, we do also see orofacial pains. That's a little low in number, but the most common, I would say, is low back ache. But it's not uncommon of late to see partial tears of joints also. We see a lot more joints because regenerative medicine has also incorporated into the pain medicine now. So now the regenerative medicine, since we are already doing interventions, now is part and parcel of pain medicine. So it has been an addition for the past 4-5 years now.
Okay. Sir, you have coming across many low back patients. So what procedure you do commonly?
See, the most common thing, common cause of low back ache, at least in India, would be disc-related pain, facet-related pain, and SI joint-related pain. Other than this, there are a host of other things, like we have seen in our own hospital here. There are plenty of other not very common, but of course we do have. So for the discogenic pain, what traditionally was happening in India is go to the nearest spine surgeon, he would operate. So world over, it doesn't happen like that. So you go to the pain physician, pain specialist takes care of you for about 6 to 7 years. And then when he feels that this patient it can benefit more from the surgery, or when he thinks there is another added impending problem like neurogenic problems and so on. So then he refers to the closest spine surgeon. So world over, that is the practice, but in India we have to accept it. But now people are more vigilant, and they are no more, they know it better that there are pain physicians and they can do a job that is required out of us.
So Krishnamurthy sir, what common procedure practice in your
as I told you, it is a multidisciplinary approach. That's what he's also doing. Like I alone cannot manage chronic pain. I got a team where there are pain nurses, there are psychologists, physiotherapists, occupational therapists. Even sometimes we have other specialized, physical therapy people like who can offer TENS mission. But it's a holistic care because one treatment which works for somebody will not work for others. But broadly, because you are asking, as you rightly said, 80% of my patients come for back pain. Another 10% for the neck pain, and only 10 more percent is the rest. But of late, there's more post-surgical pains coming, like post-inguinal pain, post knee replacement, hip replacement. So broadly saying, we just talk to them, find out what is wrong and whether, we are missing something, whether we are missing some systemic causes and whether they need to be referred to specialists. If everything is normal, there is no cause that we can identify, then we start with medical management, basically. Neuropathic pain medications, sometimes anti-inflammatories, sometimes, there are some specialized stuff like local anesthetic plasters, capsaicin cream, which is chili cream, all kind of stuff we try. And then, at the same time, we can also try physical therapies like TENS mission, acupuncture, physiotherapy, massage, and all those things. And then if they get better, that's great. If not, probably, we may have to try some injections of cortisone, Botox. We can literally, do injections in any of these joints or, epidurals or facet joint injections. And if they do respond to these injections, there is also a chance that these nerves can be frozen or, burnt, like radiofrequency ablation, where we apply thermal lesions, and which is supposed to give longer duration of pain relief. So these are the things which we can do as pain consultants and anesthetists. Okay, if nothing works, probably the other option will be to send them to surgeon if they want, or finally, if that doesn't work, I think we have to counsel them and say them to accept pain, and then we can only reduce or manage the pain rather than curing the pain completely. So of late, the reason why we both are here is to help these people here to understand some of these interventional procedures which can be done, quite safely, as an outpatient. And also, Dr. Ravi Krishna is an international expert on ultrasound pain, guided pain procedures. So he has demonstrated some of those procedures for people who have access to the equipment as well as the time to do those procedures. So it is a multidisciplinary approach, but these are the common methods I use in my clinic, for, and there is also another program called pain management, where, these patients, where nothing works, we just get them as a group, and then a consultant physician, a physiotherapist, a psychologist, a pain nurse, they all sit together and talk to them, like how they have to live with this pain. What are the ways by which they can cope with the pain rather than accept the pain and move forward in life rather than finding a permanent solution.
Sir, what is your success rate with your procedures you are doing every day? How do you think whether it needs more, more practice to make it 100%, or what is your success?
There are two ways of looking at it. The success of any procedure or intervention is finding out whether you're doing the right thing first.
Yes, exactly.
Meaning, is the pain generators that you're trying to intervene, is that accurate?
Exactly.
Okay. Diagnosis should
be spot on. Next thing is accuracy of needling in interventions. That is what our question was. So interventions and accuracies, they go hand in hand. Yes. If you can get these two things right, I think you and the patient will be the happiest.
Okay.
If either of it is missing, then we would have 30% relief and not 100%, 90% relief. So your question is, yes, diagnosis again and interventions. Interventions you get better with more and more and more in practice, like the workshops which we have done yesterday and today. So all this are to increase the accuracy of interventions. So I think I've answered your question.
Thank you, Dr. Ravi, Dr. Krishnamurthy, again for coming all the way.
Thank you. It's a very, very,
It's
very,
an honor. Thank you very
honor
much.
to
Sharing
us.
your
Personal.
knowledge
Thank
and
you.
experience with us.
Thank you.
Thank you. Thank you.